in terms of co-benefits. And in this case, we're talking about improving the quality and equity of asthma care in Australia while making our delivery models more sustainable and possibly less expensive. I think that learning to think about integrating sustainability into our evolving models of care with a co-benefit frame is really interesting and offers many exciting opportunities towards the pentuple aims of healthcare, and perhaps once we add decarbonisation, the hextuple aims. Hearteningly, it wasn't difficult to get the 50 organisations who participated to be on the same page with this process. It seemed to be just understood by everyone that it was worth thinking together about how to help the 2.8 million Australians with asthma improve their asthma control while decreasing the greenhouse impact of the 20 million high global warming hydrofluorocarbon inhalers we're using in Australia each year. So I'd like to acknowledge the experts from within the system, the representatives of the stakeholder organisations listed here who contributed to this report. The impetus for the project was the release of the Australian National Health and Climate Strategy last year, which is a critically important document, an excellent read, and has 4 important objectives, including Objective 2, to set comprehensive health sector decarbonisation targets across scopes 1 to 3. So we can all contribute to making our sector more sustainable. We currently emit about 7% of the national emissions, so the health sector is responsible for 7%. That's about the same as the whole footprint of South Australia. And most of those emissions come from the supply chain, including pharmaceuticals, of which propellant inhalers are the standout priority, as you can see from action 4.14 of the strategy here. Why is this a priority? Well, in the NHS in the UK, the estimates are that respiratory inhalers account for 13% of the NHS's carbon footprint related to the delivery of care and 3% of the total health sector emissions. In fact, the NHS modelling suggests that transitioning to low greenhouse asthma care would have a greater decarbonisation impact than transitioning to renewable electricity supply for the whole NHS. So we designed a process to respond to this strategic action. And we started by defining the problem, and it quickly became apparent that low quality, low value asthma care has a high footprint, as well as the issue of hydrofluorocarbons in the inhalers. So a co-benefit lens aiming for a win-win was going to be the most appropriate frame when working with the asthma care sector. We scanned the available data regarding asthma care indicators, the evolving evidence and guidelines. We talked to opinion leaders and looked at first mover implementation studies. The output of this scan forms the background section of the report, which we offer as a sort of a narrative review, summarising what you need to know to understand why the stakeholders have made the recommendations they have. This helped to define the challenge, to really understand the systemic barriers to this transition, and it became clear that engaging stakeholders in a facilitated, system-oriented set of roundtables to harvest insights and co-generate solutions was likely to be the most efficient methodology. And following these roundtables to design the roadmap, we continued the engagement. All stakeholders were invited to contribute to the first draft of the report to build consensus on the more clear goals and recommendations, and to highlight those that require more detailed investigation in the next phase of implementation planning. So let's look at the relationship between asthma treatment as it stands in Australia and the associated footprint, focusing on a few snippets of what we've uncovered in the initial scan. And I'm going to lean into the paediatric data here because that's my particular area of interest. So short-acting beta agonists, SARBs, or relievers, predominantly salbutamol, which is only available by propellant meter dose inhaler in Australia. They are overused and over-relied upon. And we know we're using about 15 million of them per year in Australia, probably more than half over the counter, although we aren't collecting this data in the national indicators yet. Dispensing 3 or more SARB canisters in a year is an indicator of poor symptom control and is associated with the doubling of emergency department presentations in both adults and children, with numbers rising with each SARB from there. Once you get to 12 SARBs a year, you have a 30 times odds ratio of death from asthma. Inhaled corticosteroid preventers are very effective, but are significantly underused. So, for example, in young people, a large systematic review found that adherence is about 28% to inhaled corticosteroid preventers. And we know that about 60% of asthma hospitalizations could be attributable to poor adherence across the population. So unfortunately, despite us all trying really hard, asthma care in Australia is not going well, and the numbers haven't changed for about 20 years. 1 in 9 Australians have asthma. Control is poor to very poor in half. Children are responsible for 43% of asthma hospitalisations, and the National Young People and Asthma Strategy survey highlighted that 63% of young people had poor control. 90% reported experiencing shortness of breath in the last, at least once a week in the last 4 weeks. With functional impacts, 56% reporting asthma hinders their enjoyment of life, and only half had a written asthma action plan. And we know that uncontrolled asthma is a burden for the individual, but at a national level, it's hugely expensive. The burden of disease is estimated to cost the Australian people $28 billion in 2015. The greenhouse impact of approximately 25 million inhalers sold in Australia each year, of which 80% are high global warming PMDRs, can be estimated at about 600,000 tonnes of CO2 equivalent. That's about the same as the emissions from 350,000 annual vehicle emissions, and would require 60 million eucalyptus trees per year to absorb an equivalent amount of CO2. And there are potential for compounding effects then with climate change and its causes, predominantly fossil fuel extraction and combustion, increasing asthma incidence and exacerbations via air pollution, increased allergens and combination impacts. So what are the answers? Well, we need to understand what is making up this footprint for a start. This slide is really important. Now it's not coming up, just one sec. There we are. So Wilkinson et al. In the Sabina carbon study did some really important work here. And there are two main points from this slide. The first is, so this looked at 500,000 primary care asthma patients with linked hospital episode data. And the first point is that the carbon footprint of asthma care is about 3 times greater when asthma is not well controlled. Bringing home the idea that high value asthma care is low carbon care. So this is a great example of a co-benefit opportunity. Secondly, the large majority of asthma management carbon footprint comes from the inhalers, the SABAs in blue and the inhaled corticosteroid preventers in green. So that's well over 90%, I think it's about 95%. Healthcare resource utilisation in gold and other medicines in grey surprisingly make up a very small proportion of the asthma footprint. So it's really mostly about the inhalers and particularly the hydrofluorocarbons, obviously. So how do we improve things? Well, the real opportunity here is the massive change, the quantum shift occurring in community-based asthma treatment. After decades of SABAs being the first prescribed medicine for anyone with asthma, as required, short-acting beta agonists are now out. They have no place in the international guidelines for anyone, even those with mildest disease. In fact, for everyone with asthma over 12 in the recommended treatment track 1 in the GINA international guidelines, it's now all about AIR, anti-inflammatory reliever therapy, using combination ICS formoterol as required in an anti-inflammatory reliever only regimen in steps 1 to 2, and then adding in daily dosing for a maintenance and reliever therapy, which some of you will be more familiar with. This is now being taken up in the UK by the NICE and British Thoracic Society SIGN guidelines, which are currently out for draft consultation. In paediatrics and adolescents, the guidelines are recommending the same in Australia, and we're awaiting the updated National Asthma Council guidelines in Australia, hopefully out early next year, and they're looking at this evidence now pretty closely. You're not alone if this quantum shift in asthma care has snuck up on you, but these changing guidelines away from salbutamol to AIR only or AIR with maintenance, MART, offers a significant co-benefit opportunity. So looking at going from the previous vicious cycle to a virtuous cycle, in Australia, ICS formoterol is readily available in a range of dry powder inhalers, which have 3% of the greenhouse footprint of propellant inhalers. The options marked with green on this little snippet of the device chart from the National Asthma Council are the low carbon options. There's another one called the Easyhaler, which is yet to be added. And the Asthma Council are looking at modifying their chart permanently to help prescribers know what the low carbon options are and consumers. Really important caveat, it's clear that the greenest inhaler remains the one that the person can use correctly and that will reduce their risk of SARBA overuse and of severe exacerbations. The good news that detailed in our report is that people, including kids, like dry powder inhalers. They can use them well or better than with PMDIs in the community setting with training, as long as they can take a big breath in less than 3 seconds. The potential advantage to the young person is just having one device in your pocket for air or MART, and if you use a dry powder inhaler, then you don't need to be carrying a spacer. So that's a big win. So to the roundtable process. So a series of stakeholder roundtables were held in person as well as online with reps from a broad range of organisations you saw earlier, and participants considered the question, what factors influenced asthma care quality and its environmental impact? And they developed recommended goals and actions that governments, federal, state, territory and system stakeholders could take to transform asthma care in Australia. This is the system map that they generated, and I won't take you through this in detail, but you can see that the factors are colour-coded into various themes, and it highlights the complexity of the relationships between these many factors. And this is what participants use then to go on and co-generate the goals and recommendations found in the roadmap, which I'll show you now. Now, this was happening earlier. I'm just going to skip through these just to make this slide work. There you go. So goal 1, you can't change what you're not measuring. So we need to establish a data dashboard to display the national indicators of high quality asthma care and the decarbonisation trends. And we basically need to collect a whole lot of medication and device data. What's prescribed, what's privately prescribed, what's bought over the counter, what sort of combination medicines, what kind of device with what sort of propellants. Goal 2, we need consistent recommendations as stakeholders advise that the current differences in guidelines in recent years in Australia has made implementation really quite challenging. And we need to establish processes and resources to support regular evidence review and mechanisms to make sure that we get harmonisation with secondary resources, etc. Goal 3 was around increasing clinician education and digital enablement to implement evidence-based low-carbon care, both in primary care, but also in the tertiary sector, ensuring appropriate discharge planning after emergency department or hospital admissions. And we need to design and implement integrated digital tools such as asthma action plan templates and consumer information resources, and embedding these tools in practice management and EMRs, etc. Goal 4 was around launching a research-informed multimodal national public awareness campaign targeting people with asthma and helping them understand the opportunities that are there for them, and also things like labelling devices so people know what the low carbon options are if they're interested. The goals 6 to 8 are here. I'm just going to again make these slides work. I'm not sure why it's doing that. But is that coming up for you? Yep. So we need to reduce the imbalance between the cost and ease of access of SARBAs, which at the moment are cheap and you can buy over the counter, to make the guideline concordant options more readily available, make sure they're affordable by everyone for whom they're relevant, and there is all sorts of things to take in there, including maintaining emergency access to your SARBA by the pharmacy, but potentially monitoring how many people are using, and that being a mechanism to trigger people's need to follow up with their prescriber to look at their control. Goal 6 was around supporting research to implement and evaluate high quality sustainable asthma care and to think about research that matters to people with asthma. Goal 7 around reducing greenhouse gas emissions by minimising the residual hydrofluorocarbon leakage from discarded asthma inhalers, which would involve returning them, for example, back to the pharmacy and then going to a destruction site so that the inhaler can be burned at high temperatures so it can't leak into the atmosphere. And goal 8 was taking a step back to the big picture and supporting the national strategy objective to develop a health in all policies approach to reducing the modifiable inducers and triggers of asthma. So, for example, improving our energy and transport policies and regulations to improve air quality, that knowing that would bring a reduction in asthma incidence and exacerbation rates. And there are some things already happening there: the recent fuel quality standards, the Idle Off campaign, and a range of other things. But there's much more to be done. And then we just talked today about what needs to happen to progress the roadmap, including establishing a collaborative body to develop a detailed implementation plan from here, undertake a detailed economic evaluation to assess the likely return on investment of the various implementation strategies, and then to provide governance and resources to deliver a collaborative national sustainable asthma implementation plan. So this is really just the start, but it's been fantastic to see how keen all these stakeholder organisations and peak bodies are to be part of this. I'll jump off there just to leave you with, there's the scan code again, and if you want to have a look at the report. So to round up, transitioning to high quality sustainable model of care is something we can all be part of in our practice, hospital and other areas of influence. Check out the full roadmap report via this code. For more details on AIR and MART, check out the GINA 24 report. There's a nice slide deck there that they've got freely available to summarise the evidence. Remember that a dry powder inhaler will be relevant to most people, so consider that option when you're talking to your patients. And thanks very much again for inviting me to join this grand round and for your interest today.
Wonderful. Thank you so much, Mike. And it's been a very busy day for you, but I know the last 8 to 10 months you have been working so hard on this, and it is quite an extraordinary report. And someone put the link in the chat already before. So whilst you're thinking of your questions, the link is there as well. And we now have a few moments for questions. So please raise your hand if you can. I'm sure there are, a few questions that we could be asking Mike. It's quite extraordinary, isn't it, that asthma or the metered-dose inhalers are such significant greenhouse gas emitters, and that we, particularly in Australia, have been so slow at appreciating this. And I think a lot of medical professionals still have no idea. But even separate to that, as you say, low carbon care is high value care. And wondering your reflections, why Australia has been so slow in updating what seems to me to be evidence-based best practice guidelines. I met someone at your launch this morning who said our guidelines were basically third world guidelines when it comes to asthma treatment.
Yeah, okay. So the National Asthma Council drives the Australian Asthma Handbook, and they're a not-for-profit. They've been doing this on a not big budget for some decades. And so one of the recommendations was that we need to support them to really do evidence reviews more frequently. So GINA does this every 12 months. They look at the last 18 months of international evidence every 12 months and update an international strategy. The Asthma Council needs help to do that here. There was alignment already at sort of steps 3 to 5 around MART. They weren't convinced when they last wrote the guidelines 5 years ago that the evidence was there for AIR, but they're looking at that again now. And that will probably, I think the asthma handbook will probably start to look more like these guidelines. That's what we hope, because that will make implementation much easier and minimise confusion. Yeah, I think that's really the answer.
Okay, but it's interesting, isn't it, that they haven't been updated for 5 years as well, and when it seems to be like a relatively fast-moving area, definitely in the last 5 to 8 years when it comes to evidence-based.
Yeah.
I'm wondering if there are any other questions.
I can tell you, while people are thinking, one thing we were early on was the previous transition from chlorofluorocarbon inhalers to hydrofluorocarbon inhalers. Australia was the first, and the two champions who led that, Helen Tope from the UN Montreal Protocol Group, she remains the co-chair of that. She's been involved in this process, and Christine Warlow, who was the CEO of the National Asthma Council, they worked together, and she's also been involved in this process. They really led that here. So we can be a first mover on things if we get together, because we're a fairly wealthy country, and we don't mind charging ahead on things sometimes. But yeah, we just need the impetus. the buy-in here has been really strong. So, maybe we will move fast on this now. We'll see.
Okay, great. Ben, did you have a question?
Yeah, one quick question. Just for, I'm not personally involved in asthma care in my hospital, but for anyone online who is, I know you're saying that there's some guidelines have come out with the recommendations that you outlined, but the asthma handbook hasn't been updated yet. Is there anything stopping those kind of involved in asthma care at the moment from updating their own local kind of policies and guidelines? Or do they have to wait for the national asthma
No,
guidelines?
there's not. So, for example, in pediatrics, the Children's Hospital guidelines have morphed into a pediatric improvement collaborative, which involves multiple states and New Zealand. I'm pretty sure, or at least they're certainly aligned with the New Zealand asthma guidelines, and they are basically GINA aligned guidelines. So, the Thoracic Society is about to release a position paper on something similar. So, no, hospitals can go ahead, and that's both a strength and a challenge. It's great that everyone can, do what they want. On the other side, it would be great to have something like the UK's National Institute for Clinical Excellence, which becomes the resource and is the go-to resource for everyone, which then makes a national implementation much easier. But no, it's already happening. That organisations are already forging ahead if they think the evidence is compelling enough. Yep.
Okay, excellent. Maybe another question then. Right. So no, Jonathan has put his hand up, so let's go there.
Just jumped in there. Thank you. I was a little late arriving. I work in mental health, and I think people with mental illness have, got a commitment to the environment as much as all the wonderful people here. So hopefully you may have covered this, and I missed it. Sorry if I did. But
we did.
Do you have thanks. Do you have a simple? Is there an idea of putting that choice back into the client's hands, the consumer's hands, about maybe I don't know, simple things, ask your doctor if you could have a low carbon option, things like that. Is there sort of a simplified version?
Absolutely. So one of the goals there is around delivering a multimodal awareness raising campaign for people with asthma about how they can improve their care and the things they can talk to their prescriber about. It's incredibly important that this is consumer led, and that's why we ran this project in partnership with Asthma Australia. It really needs to be it needs to be about shared decision making and making sure people have the resources at hand to help drive this, and make sure that people don't feel stigma if it turns out that a propellant metered dose inhaler is better for them. I should say that for those who will need PMDIs, kids under 6, people with frailty, or people who just struggle to use a dry powder inhaler for whatever reason, there are potentially some low global warming potential hydrofluorocarbon propellant inhalers coming, but we don't know when. Could be years. We don't know. I can also mention that at Deakin we've got a team working on a zero carbon active DPI type propellant inhaler that could be helpful if that works. So we'll see. And one last thing to say about people with mental illness is something that's come up in some discussions is that you don't want to burden people with multimorbidity. So that's what is actually so elegant about this, is that this is, with these new guidelines, it's one device, which you either just take as required or you take as required and daily. That's all you have to remember. You don't have to even remember your spacer. So in terms of making things easier for people, I think this is a really important step forward.
Oh, great. Thanks.
Thank you. And you might have answered in that sense, I think, just then, Mike, the question in the chat about are there any future new suggestions for treatments for those under 12 years, and how many hospitals use burst therapy with inhalers?
Okay, so to the first one, the GINA guidelines at the moment are recommending this from 12 up. From 6 to 11, the recommendations are almost air and mart, but they're basically saying every time you use your SABA reliever, you should also be using an inhaled corticosteroid. And there are 5 trials underway in this age group to actually just make it easier and just move to this air and mart regimen. So that's probably going to be the recommendation in the GINA 25 guidelines. There's also one of those studies called the CARE study, looking at air in primary school. There's a pre-care study looking at this in preschoolers, and that's going to be an interesting space to watch as well. But that's that would almost certainly need to be delivered by propellant metered dose inhaler for the majority of kids. Yep.
Yeah. Okay.
And then the question about acute care, that wasn't really covered in this roadmap. It's absolutely recognised as an area that requires some investigation and thought. What we need is some more evidence around dry powder inhalers in acute care. If you're in Sweden and you're on an air regimen and you went to hospital, you would continue on your dry powder inhaler in the ED. If you were in the UK, you would drop your dry powder inhaler and go to nebulizer. And if you're in Australia, you would go to a PMDI via spacer. So it's a little bit cultural. And there's some work that needs to be done there. Yep. I was talking to the team today about the need to run a trial looking at people who are admitted to the ward coming in on a PMDI and then trialing them on a DPI while you're working them towards discharge and sending them home on an air MART plan with a DPI if it suits them. So I think that's a trial that would be really good to run.
Wonderful. Okay. Well, thank you. Look, it sounds like, Mike, you've not only do you have a lot of research questions to answer and keep you busy for the next few years, but also an implementation plan now for your roadmap to instigate. So no rest.
It's a whole new world for this clinical paediatrician, but it's interesting stuff.
And I must say, Mike, it's just absolutely amazing what you've done with this and leading that over the last year. So a really big congratulations and thank you very much for presenting today. All right. Wonderful. Next we have Dr. Ben Dunne, who I think many of you probably already know. He's a thoracic surgeon at the Royal Melbourne Hospital and Penna McCallum Cancer Centre. He is the Royal Melbourne Hospital Clinical Sustainable Lead and Chair of the University of Melbourne Environmentally Sustainable Surgery Network, and also co-convenes DA, Doctors for Environment Australia's Sustainable Healthcare. He works with the College of Surgeons as the chair of their Environmental Sustainability Working Party, and is an absolute powerhouse as well within the university, working with myself and others around sustainable healthcare. And he's going to be presenting this afternoon on reusable sterile surgical gowns and drapes, back to the future. So thank you very much, Ben.
Thanks very much, Eugenie, and thanks very much for showing up and listening to me today. I'm going to be presenting a far less impressive piece of work than what Mike's put together, but we've certainly taken a lot of inspiration from what he's done and hope to kind of learn from what he's been doing and see how we can take our work forward. But yeah, I'll be talking about reusable sterile surgical gowns and drapes. Why are we talking about that? These are slides and diagrams that many of you may have seen before, and we're talking about waste because, as you can see, and a large waste from hospitals because, as you can see, a large proportion of healthcare's emissions in Australia come from public and private hospitals. The graph there on the left shows that it's about 45% of Australia's healthcare carbon footprint. But when you frame it in a different way, and this is data from the NHS, which is not directly applicable to Australia, but close enough, about 60% of the carbon footprint from healthcare delivery is the stuff that we use every day to deliver care to our patients. So, the stuff that we use in the hospitals is an obvious target for us to try and tackle. But why surgical waste in particular? Well, surgery is very carbon intense, largely driven because of the fact that about 30% of hospital waste is generated in the operating theatres, as well as us using a significant amount of energy. The bulk of the carbon footprint from any operation is actually from the disposable equipment, gowns, drapes we use. And, we have all seen a move away from reusable versions of these items, but that hasn't really been based on strong infection prevention evidence. It's been industry driven, and it's been along with a bit of short-term cost shifting on the part of health services and convenience as well. But it's really a prime target to try and tackle. To put that into a more visually striking depiction, this is a Dutch artist who put all the single-use equipment from her breast cancer procedure into this particular image to create an art installation that really conveys the scale of waste generation. Really, I think it was 2 different procedures she had, but really the scale of waste that comes out of the operating theatre for each patient. And to look at instruments first before we get on to gowns and drapes. This shows that it's not only possible to reduce the environmental impact with reusable instruments, but actually saves money at the same time. This was a study done out of the UK looking at the emissions associated with 3 different instrument sets for laparoscopic cholecystectomy. So moving to those reusable instruments, the emissions were reduced by 50%, and the cost was reduced by 50% as well, the cost per case, even though the individual items might have had a slightly higher upfront cost. So really the question is, why aren't we not moving away from the single-use items towards reusable versions of things? But even though it might sound like it's, a no-brainer, there's actually a lot of barriers that I came up against when, I first started looking into how we could start moving away from the single-use gowns and drapes. And I was really quite surprised at how many of them were there. There was, arguments that they weren't safe from an infection prevention perspective. They don't provide adequate protection to staff from bodily fluids. They don't comply with the ACORN standards. That's the Australian College of Operating Room Nurses. Staff don't like them. There's actually no real environmental advantage over the single-use gowns. They're not available, they're too expensive, and there's just too many logistical and contractual challenges to make it work. But I was pretty determined that we could find some evidence and solutions to most, if not all, of those barriers, because they didn't seem insurmountable. So we started with a plan to collate the available evidence and bring the various peak bodies responsible for some of these decisions together to endorse an evidence-based position statement. And we started with the Royal Australasian College of Surgeons, ACORN again, as I mentioned, and the Australasian College of Infection Prevention and Control. And I'd like to thank Caroline McCallum, who's one of the breast cancer surgeons at Royal Melbourne, who really did a lot of the work behind this and was a real advocate for this work and the document coming together. We started with asking, are they safe for our patients? That's really the most important question. And thankfully, most of this work had already been done for us with 2 systematic reviews and meta-analyses from pretty well-respected bodies, the World Health Organization, as well as the Center for Disease Control in the US. Both of these clearly came out stating that reusable gowns and drapes were equally effective as the single-use versions when preventing surgical site infections in surgical patients. So we were off to a pretty good start there, determining that, yeah, it's pretty safe for our patients to go with reusable gowns and drapes. But that did not necessarily address staff concerns, and thankfully, again, there are some pretty clear standards set out there for barrier protection for any procedural gown. So any gown must be able to demonstrate that they can meet the barrier standards. Level 1 not being suitable for any procedural work, and level 4 being the highest for like high volume liquid exposure. But in reality, operating theatres usually stock level 2 and 3 barrier gowns. And any gown on the market must clearly be labelled as to what level it's performing at. And again, we're pleased to find that someone else had gone away and done the hard work here and compared a range of single-use versus disposable gowns in the US. Not necessarily the same ones available in Australia, but we can see that certainly for the level 1 and the level 2 gowns, the disposable gowns were not at all performing at the minimum acceptable standard, although the level 3 gowns appeared to be. But the reusable gowns clearly passed the tests at all 3 levels very safely. So they're definitely safe for staff to use. There are, of course, important standards that need to be met for any medical device or medical product, which gowns and drapes are considered a medical device by the TGA. However, again, these are pretty clearly defined, and any provider of the reusable textiles just has to produce evidence that they meet these standards and have been independently assessed. So this burden does fall on the supplier. So any health organization just needs to make sure that this information is provided to them by a supplier of reusable linen if they want to make that change. We come up against arguments again that, maybe staff don't want to change. On the whole, surgeons have been a fairly conservative bunch traditionally, but back in 2021, we did survey all of the College of Surgeons fellows and trainees, and for at least those who responded, over 80% were keen to move to reusable gowns and drapes if they were provided with some assurance and guidance that it can be done safely. So as a profession, we realize this is an urgent problem, and we are willing to make the changes to our practice if we're provided with a bit of guidance. Maybe staff don't actually like it once they try them. And there's, historical concerns that staff preferences are in favor of the single-use gowns. But that wasn't really borne out by data either. There's a study by Conradi that showed that over 80% of staff in the study done in the US preferred reusable gowns and drapes for their personal preference, and also thought they offered greater protection. Now next, is there really an environmental advantage when we factor in transporting them back to the laundry, sterilizing them, using all the soap and water and cleaning chemicals? Well, unreservedly, the answer is yes. On every metric from resource utilization, global warming potential, water use, and waste generation, reusable gowns outperform single-use versions by a long way. So that argument really got put to bed. So we brought all this information together into our position statement and summarized it, and we're able to state that reusable gowns are safe for our staff, safe for our patients, and much better for our environment. And the real key to bringing those three organizations together in this was to engage them all early, get everybody talking, make sure everyone was on the same page to move forward, take a really robust approach to the data collection and evaluation, and have an openness to discussion and revisions around it as well. If you want to actually read the document, it's not that long, it's not that boring. There's a QR code there on the screen that you can follow and actually takes you to the College of Surgeons website where it's hosted. And we've been really delighted with the response from a lot of other colleges and societies as we've sought broader endorsement of the position statement. We're now up to 11 further organizations that have endorsed the statement, which really helps bring clinicians on board if they know that they have the support of their craft group and kind of specialty society. But has this actually achieved anything, or is it really just another piece of paper on a college website? Well, it certainly helped raise awareness on the possibility of making these changes among surgeons and also among anaesthetists. We had a number of sessions at the College of Surgeons ASC, as well as an ANSCA event in the last year or so. It helped get 3 pilots underway, one at Peter MacCallum Hospital, one at Belmont Hospital in New South Wales, as well as a smaller one in our cath lab in Royal Melbourne. And it even got the concept of moving back to reusable surgical textiles mentioned in the National Health and Climate Strategy, with this photo of Hayden Snow here from Peter Mac, who was in charge of their pilot study. I'd particularly like to congratulate Hayden and the Peter Mac team, as I saw yesterday that they've been listed as a finalist in the Victorian Public Healthcare Awards in the sustainability category for this project, moving Peter Mac back to reusable gowns and drapes, which is fantastic. And this is some of the results from that pilot. Because local data is always more powerful when you're looking to make some change. But it showed pretty conclusively that reusable gowns and drapes were either better or equivalent to their disposable counterparts. And I'm looking forward to seeing this in publication pretty soon. There's definitely some barriers remaining. It would be great if we could definitively say that they were cheaper than disposable gowns, but we can't be confident about that just yet. It does seem as though they're roughly cost neutral, particularly when you factor in removing the existing single-use gowns and drapes from the surgical custom packs that many theatres use, and also factor in the cost of clinical waste disposal, which is where all the single-use gowns and drapes go. There's always going to be some logistical challenges. There needs to be a system set up where the gowns dropped off by the linen company, stored, collected, after they've been used and taken away to be re-sterilized by the company, and then brought back, which is a little bit more complicated than just putting everything in the bin. Are the gowns and drapes available to every hospital in Australia right now? Probably not everywhere can access them at the moment. There's 2 companies, certainly that can provide hospitals in Victoria with reusable surgical linen, but I'm not quite sure about the availability throughout the rest of the country, particularly in more regional and remote areas. And lastly, there are some contractual hurdles for some health services because we do have linen contracts for non-sterile linen that don't explicitly get into the contractual requirements for sterile linen, but they might have some clauses that you'll need to work around individually in your health service. So where are we going from here? Well, we're nearing the final stages of a plan to hopefully follow along in the example set by Peter MacCallum and bring hopefully all 4 Parkville precinct hospitals into a contract for sterile linen. So it would be Peter MacCallum Hospital, the Royal Melbourne Hospital, the Women's Hospital, and Royal Children's. So considering that that's almost, I think upwards of 50,000 procedures a year, probably closer to 60, I think, that would really be a transformative change in terms of how much waste generation how much waste we generate on the precinct. So between the positive results of that initial Peter Mac pilot and that plan, we really hope that will be able to build further awareness and drive change as other places hear that not only is it, feasible in theory, but it's actually doable in practice. And I can't really help myself, I'm followed on from Mike's talk, to think about whether a similar national roadmap approach is needed for this problem, because, it really is an area where we need to have industry, health services, clinicians, procurement teams all working together to find out how we can make this change at scale. But it's not just gowns and drapes we're thinking about, because there's certainly many other examples of waste we can reduce in the operating theatres, from the single-use theatre caps single-use shoe covers, the overuse of TED stockings, as well as trying to phase out the traditional surgical scrub for, certainly much less wasteful, much more water-friendly alcohol-based surgical rubs, which are just as effective. So we've been working on similar evidence gathering and position statements for each of those issues, and we're hoping to see a tide of change in surgical practice in the years to come on a number of fronts. That's really about it. Thanks very much, everybody, for listening. Happy to take some questions.
Wonderful. Thank you, Ben. And again, I really have to congratulate Ben on that position statement, spending a lot of time and effort, I know, with others, but to get that across and to be really led by Rax and you, which is absolutely fabulous. And it is, as you said, another situation where the evidence is there that we can be using reusable gowns and drapes in so many areas, yet the practice is not there as yet. And we really do need to change that practice. It would be great if we did have some questions for either Ben or Mike again as well, because he's got his camera back on. Ben, you were talking about the carbon footprint of disposable products in the theatres. 70%. Do you want to just tell us about that again? 70% of the carbon footprint is from disposable products in theatre. Yeah. Is that right? And what percentage of that is drapes and gowns? Do you know again?
Off the top of my head, I can't quite remember. It's related to drapes and gowns. I know that's a study done by a woman called Chantal Ruzan, who's like a massive researcher in this field from the UK. She's an ENT surgeon. And basically they took the 5 most commonly performed procedures in the NHS and broke down the carbon footprint for each of those and worked at their proportion, what proportion of the carbon footprint of each of those operations was due to disposable items. And it was somewhere between kind of 55 and 70% across those 5 operations. And that was the important thing that they took it out was, the single-use items were the biggest contributor. But even when you recycle some of those, the recycling of them really only takes about 10% off that carbon footprint. So it's really not the answer. It's really, having to redesign the processes that we have in place to go back to having reusable versions of things.
Yep, absolutely. And as you say, and some of your work and others, I know at Western as well, they actually find that people who are using the reusable gowns actually prefer to wear them as well. They're more comfortable. Is that right? As someone's put in the chat as well, when it comes to infection control as well, it's not just in theatre, it's on the wards.
Yeah, so I think there's the intensive care study out at the Western where it was sort of infection prevention barrier gowns. They certainly much preferred those to the single-use barrier gowns for infection prevention. And yeah, we have our kind of Peter Mack and that other study from the US about surgical gowns. So again, it seems pretty convincing that, staff do prefer the reusable versions.
Okay. So please feel free to put your hand up and ask a question or put it in the chat and I can read it out then. I'm happy to do that. I think you also said that the disposable gowns, some of them are not actually passing the level 1 and 2 criteria. Is that right? So are we buying disposable gowns that are not actually fitting the recommendations?
That's one study done out of the US. I can't say for sure that applies to the single-use gowns that are used in theatres in Australia. We haven't studied it. It would be interesting to do. I know that companies that use the reusable gowns have some pretty rigorous testing. They undergo the gown is tested every time it's sent back to be washed. Yeah, I think they have to prove that. There's some pretty stringent requirements around reprocessing of medical devices, and a gown is considered a medical device by the TGA. But as far as the single-use gowns that are shipped in from overseas in a already sterile package, there's no system in place for them being tested in Australia. So there's more of a, an honor system in place there.
Okay. All right. Well, there's one question here, and then we can easily wrap up earlier because I'm sure everyone's got things to do. But does anyone's got supplier details for level 3 gowns for colonoscopy that private endoscopy providers can use?
Oh, I think both of the companies that you don't need sterile gowns for those procedures, but both Linen Services Australia and Retex, I think both provide sterile level 3 gowns. Whether they provide non-sterile level 3 gowns is another question. But they have the technology to make them.
Yeah, and you said they have the technology to make level 3 gowns, which you might need for colonoscopy because that's the barrier, I would think. Yeah. Okay, that's fabulous. And all right, well, we might wrap up, I think, if there aren't any more questions. And I should actually point out, Ben mentioned that Hayden Snow was a finalist for the Victorian Public Health Sustainability Awards, and that also Ben and Sonia Chantelanti are also finalists from work they've been doing at the Royal Melbourne Hospital around the sustainability competition for those awards. So big congratulations to you. Oh, I think, which is absolutely fabulous. And we do have one question then, sorry. Is that Jonathan? You've got your hand up?
Yes, sorry. Oh, well, not sorry, but anyway, I just think it's fantastic. Just say hats off to you, Ben, and all those other people that got behind this initiative. To me, it would be an impossible task when you see all those huge mountains of plastic gowns proliferating like some sort of, I don't know what the word is, but and I think there's a link. I always think there's a link between our commitments to acknowledge the custody and the care of the land from the First Nations that we have on all the before every meeting and on all the doors, and this is kind of making it a bit real. And I think people would love to know that these efforts are going ahead, and I reckon I think a lot of people would be really rapt to know that all these efforts are going on in the hospital where they're going to get cared for.
Yeah, I think there's a real interest in it, and certainly at some of the surgical conferences that we've been and spoken at, there's real enthusiasm for surgeons to get behind it. I know there's been a bunch of stuff in the chat about the non-sterile ones and the barrier isolation gowns, and certainly the companies that make these sterile gowns also make non-sterile barrier isolation gowns. But I think there's a number of companies that do the reusable barrier gowns. So it would be up to each individual organization to assess those for quality and for kind of the price associated with them as well. But it's
that's great stuff.
Right, thank you very much, and good point, Jonathan. We do have the ethos of first do no harm, and there's many ways that we can reflect on that in our work practices. So before we finish up, I'd like to just also remind everyone or point out that the next University of Melbourne Sustainable Healthcare Grand Rounds is coming up on the 13th of November, again at 4 p.m. And we have Monique Ryan, who will be speaking at that, along with Karen Kean, a paediatrician at Royal Children's Hospital. So put that one in your diary, and we hope to see you there. And thank you again, both Mike and Ben, for presenting on, at the end of a very big day. So congratulations, both of you, for everything.
Thanks for sharing, Eugenie, and thanks to everyone at St. Vincent's for continuing to host this grand round on a monthly and then quarterly basis for the university. So,
great. Okay, take care.